The following case study is about Judy, a traumatic brain injury patient. This presentation is by Laura Homan, Taylor Vento, and Molly Almas. Judy is a 54-year-old wife and mother who sustained a traumatic brain injury following a motor vehicle accident. Judy's injury was a closed, diffuse brain injury caused by the force of the impact. As a result, she will be in inpatient rehab for 3 weeks. According to Pedretti, a traumatic brain injury is defined as damage to brain tissue caused by an external mechanical force with resultant loss of consciousness, post-traumatic amnesia, skull fracture, or objective neurologic findings that can be attributed to the traumatic event on the basis of radiologic findings of physical or mental status examination. More specifically, Judy sustained a closed, diffuse traumatic brain injury. A closed brain injury is usually a result from a direct or indirect impact without penetration of the brain tissue. Diffuse brain injuries most commonly occur in motor vehicle accidents, like in Judy's case, where there is rapid movement of the head. The below link is a good source to better understanding the brain and how traumatic brain injury affects it. Typically, when a patient presents with a brain injury, the Rancho Los Amigos Levels of Cognitive Functioning Scale is used to categorize the patient's level of cognitive function via behavioral observations. This scale ranges from levels 1 to 10, with 1 being the most severe state characterized by no response to visual, verbal, tactile, auditory, and noxious stimuli, and 10 being the highest level, characterized by purposeful and appropriate behavior as well as modified independence. The first 3 levels describe the patient's response to stimuli and the environment when emerging from a coma. This scale is very helpful in medical practice because it allows clinicians to better communicate amongst themselves and with the family about a patient's level of cognitive function, and it also contributes to the development of appropriate rehabilitation strategies. Judy is a Rancho level 5-6 and thus had improved from inappropriate to appropriate responses but remains confused. When at level 5, Judy is able to respond to simple commands but is more confused with complex commands. She can grossly attend to the environment but is highly distractible. At level 6, Judy begins to show signs of understanding and demonstrating more goal-directed behavior, but continues to require external cues to stay on task. She also begins to become more functional to complete her common daily activities. In the past, Judy has been treated for chronic back pain and anxiety and remains an avid smoker. Prior to admission to the hospital, she was independent in all ADLs, IADLs, leisure activities, and community mobility. Judy takes several different forms of medication, including Ritalin to address her distractibility and short attention span, Prevacid to treat her stomach condition, Singulair to prevent and control her asthma, and also Coumadin to prevent deep vein thrombosis. Additionally, Judy takes a daily multivitamin and has no reported allergies. Judy lives at home with her husband and her adult children. 1 son and 1 daughter live close by. She lives in a 2-story home that has 5 steps leading to its entrance. She was not employed prior to admission but volunteered regularly at the local hospital. When she wasn't participating in volunteer work, she enjoyed shopping and engaging in cognitive stimulation activities such as playing cribbage and Sudoku. Judy was an optimistic individual prior to her injury and is thus currently very motivated to recover and get back to doing the things she both needs and wants to do.
The evaluation process begins with an evaluation that focuses on finding out what Judy wants and needs to do and identifying the factors that act as supports or barriers to health and participation. We started with a vision and visual perception screening before beginning additional assessments. No visual or visual perception deficits were found in Judy. The main assessments we utilized for Judy were the COPM, a goniometer for range of motion, a dynamometer for strength, the Ashworth scale, the FIM, and the KELS. The COPM is the first major assessment we performed on Judy. The COPM, or Canadian Occupational Performance Measure, is designed for use by occupational therapists to detect change in a client's perception of occupational performance over time. The COPM is client-centered and is intended for use as an outcome measure, meaning it should be administered at the beginning of occupational therapy services and again at appropriate intervals afterwards. The COPM identifies problem areas in occupational performance, provides a rating of the client's priorities, evaluates performance and satisfaction relative to the identified problem areas, and measures changes in a client's perception of his or her occupational performance over the course of occupational therapy intervention. Through the COPM, we identified the most important occupational performance issues for Judy. These occupational performance issues included self-care difficulties with bathing, dressing, and being able to brush her teeth, being able to volunteer at church, which is a very important part of Judy's routine, and concerns with being able to play cribbage and Sudoku. The interview resulted in identifying an important goal for Judy, to be able to return to her volunteer work at her local church. Here's an example of the Canadian Occupational Performance Measure form that was filled out for Judy. We used a goniometer to evaluate Judy's range of motion. This assessment found that Judy had significantly decreased range of motion in her right upper extremity that is not within functional limits. We also discovered that passive range of motion is painful in her right shoulder and wrist. We then used a dynamometer to assess Judy's hand grip strength, which is important for her activities of daily living and functional mobility. The results of this test found decreased strength in Judy's right upper extremity when compared to her left extremity. The Ashworth scale was designed to quantify the degree of hypertonus. It has been found to be a reliable scale for assessing spasticity. The Ashworth scale is performed with quick, passive movements of the upper extremity joints. Judy scored a 2 on the Ashworth scale throughout her right upper extremity, indicating marked increase in muscle tone. The FIM scale, or Functional Independence Measure Scale, assesses physical and cognitive disability and focuses on the level of disability, indicating the burden of caring for the patient. It is often used to measure the patient's progress and assess rehabilitation outcomes. Overall, the results of the FIM suggested that Judy requires minimum assistance on all ADLs and moderate assistance on all transfers. We also observed that Judy presents with right neglect while performing many of her ADLs. Here's an example of the FIM form that was filled out for Judy. The CELS, or Coleman Evaluation of Living Skills, is an evaluation designed to assess basic living skills by using a combination of interview and task performance items. The CELS identifies the areas of daily living in which a person can perform and those in which the person needs assistance. The CELS is useful in measuring the level of independence a person has and helps occupational therapists make recommendations for appropriate living situations. Here is a sample CELS form filled out for Judy, indicating the areas that Judy needs assistance in. These areas include self-care, safety and health, community mobility, and leisure activity. Judy was scored as independent for money management because her husband typically takes care of that. Also, Judy did not have a job prior to her accident and has no plans for future employment.
Judy's primary problems exist in the domains of ADLs, leisure, and education. The ADLs she has difficulty completing are bathing, dressing, grooming and hygiene, toileting, and functional mobility. Due to her injury, Judy is having difficulty participating in the leisure activities she once enjoyed owing to her decreased attention, memory, and ability to appropriately sequence. Also, education is a current problem area for Judy. Because Judy is having problems with her memory, safety, proper transfer and dressing techniques, as well as the use of adaptive equipment are big concerns.
Due to the Rancho level of Judy's sustained traumatic brain injury, many domains were affected. Judy has increased tone in her right upper extremity, which decreases her motor functions. Judy has decreased fine and gross motor skills. She has difficulties with coordination and balance due to her right neglect. With her motor impairment, Judy also has trouble with functional transfers from her loss of coordination, upper extremity and lower extremity strength, specifically on her right side. Her morning routine is also affected because she has right neglect. She often forgets to brush the other side of her teeth, wash the other side of her face, and also brush the other side of her hair. Judy's roles include being a wife and a church volunteer. Judy took care of most of the cleaning in her household and also helped with various church activities in her congregation. Due to her decreased attention, safety awareness, and motor functions, she can no longer do any of these things. Judy's home will need to be adapted for wheelchair mobility, as well as her transportation to the church. Judy will also need help driving to the church. This will greatly impact Judy's social life. Client factors for Judy include decreased strength on the right side, decreased range of motion due to tone on the right side, decreased global mental functions due to her emotional ability, and decreased specific functions due to her decreased sustained attention. Areas affected in activity demands include body functions since she has loss of mobility.
The increased tone in Judy's right upper extremity, as evidenced by the Ashworth scale, causes decreased and painful right upper extremity range of motion, which results in decreased functional use of her right upper extremity that requires Judy to have minimum assistance while performing her ADLs. Our first long-term goal for Judy was that she would be able to demonstrate completion of all ADLs with modified independence by discharge. Our short-term goals that build up to Judy being able to achieve this long-term goal include demonstrating use of both upper extremities for dressing, performing ADLs without cueing with supervision by the end of week 2, and demonstrating correct use of adaptive devices for all ADLs. Interventions we utilized to help Judy work towards achieving this goal include neurodevelopmental therapy, daily ADL retraining with fading physical assistance and cueing, introducing adaptive devices for dressing and eating, and progressively increasing passive range of motion of the right upper extremity to prevent the development of contractures and increase right upper extremity range of motion. Passive range of motion programs are typically used in conjunction with positioning to minimize the development of contractures from abnormal muscle tone. Passive range of motion can be difficult when muscle tone is increased. Inhibitory movements opposite the abnormal tone are performed slowly, holding the stretch until muscles relax.
According to Judy's occupational profile and the COPM results, she used to volunteer at her church before her accident. She has expressed to the therapist that this is an area she would like to continue when she is discharged from the rehab. In order for Judy to continue her volunteer work, she must gain her functional mobility back. Based on her FIM scores, range of motion measurements, and manual muscle testing, Judy needs to work on her functional mobility and transfers in order for her to return to her volunteer work. The occupational therapist, Judy's husband, and Judy work together to create her long-term and short-term goals. Judy will have assistance and be discharged to adult daycare when she leaves. Judy will need to be able to demonstrate transfers with supervision by discharge. In the 3 weeks leading up to discharge, Judy's short-term goals will include demonstrating sit-to-stand transfers within the first week of therapy, demonstrate a wheelchair-to-toilet transfer with minimum assistance by week 2, and by the end of week 2, be able to demonstrate all transfers with minimum assistance. To help Judy reach these goals, The OT has come up with several interventions, including helping Judy build up her upper extremity strength by practicing transfers with just arms to push off, introduce adaptive equipment throughout learning various transfers, and practicing functional transfers such as sit to stand, wheelchair to chair, and wheelchair to toilet. According to Judy's FIM scores, she requires minimum assistance in her memory and showed right neglect. Because of these deficits, Judy has difficulties paying attention for long periods of time, decreased safety awareness, and often forgets what she is doing. In order for Judy to be discharged in 3 weeks, the therapist must address these areas in order for her to be functional when she is at home and in the community. Judy's long-term goal is for her to demonstrate sustained attention for a minimum of 30 minutes while attending to ADL tasks by discharge. In order for Judy to meet this goal, she must complete 3 short-term goals throughout therapy. The first short-term goal is that the client by the end of week 2 will no longer require cueing to remember how to complete self-care tasks. Her second goal is to sustain attention during therapy for at least 15 minutes without a break by end of week 2. Her third short-term goal is that she will be able to complete her daily schedule with the use of a checklist by week 3. Some interventions that the therapist will implement during Judy's stay will be incorporating Sudoku into her therapy sessions to help with her cognition, specifically her attention. This is a great occupation-based approach since Judy mentioned before how she enjoyed doing Sudoku before her accident. The therapist will also develop a checklist for Judy so that she can eventually follow the checklist independently to perform her daily schedule and routines. To prepare Judy for her discharge home, the therapist will implement the use of post-it note reminders to cue Judy with safety precautions and also substitute for external cueing for other ADL tasks like helping her with her right neglect. Judy's intervention approaches will include establishing an adapted daily routine, restoring range of motion and strength, adapting her functional mobility, and preventing falls, and safety education to also prevent injury. Frames of reference used will be biomechanical to restore function by increasing range of motion and muscle strength to help with functional mobility, and rehabilitative by using Judy's occupations and adapting her environment to promote rehabilitation of her neurological functioning. Judy's services will include occupational therapy service in an inpatient rehabilitation setting. Judy will also be referred to physical therapy for her right lower extremity weakness and ambulation. However, these areas will also be addressed in occupational therapy during transfers and performance of ADL tasks. Judy's therapy will either take place in her room to work on transfers and ADLs or in the rehab gym where the therapist can work on occupation-based interventions, strength exercises, and stretching. Judy is more alert in the morning, so her 1-hour session will take place before lunchtime. Her therapy will be 5 days a week for 1 hour every day for 3 weeks. Judy will be discharged home with her husband, and she will also be attending adult daycare while her husband is at work. After 3 weeks in an inpatient rehab, Judy met all of her occupational therapy goals by discharge. The therapist made suggestions to Judy's husband to help Judy transfer in and out of the car and also demonstrated the proper techniques to do so.
To conclude, here's an overview of our journey with Judy throughout her time in occupational therapy.